Hello and welcome to this class on evidence-based medicine. This is the first of 4 classes in the Department of Family Medicine at Barcelona Pradana University of Medicine and Health Sciences. I'm Professor Dr. Anthony Cummins. Before we begin, may I just point you to the EBM core curriculum folder on Moodle, plus also this link here towards the Center for Evidence-Based Medicine at Oxford University. This is an excellent source of templates and tools to help your understanding of evidence-based medicine. This is the outline of what we will do. Present you with some learning outcomes, then explain what is this approach to healthcare delivery called evidence-based medicine and evidence-based practice also. Explain to you why you should learn those skills, and throughout the content is illustrated with cases here and here. We look at decision making, we look at the role of the pharma industry and their support for clinical trials and so on. We look at how absolute risk versus relative risk can present the same data in different ways, can be persuasive or not persuasive. We look at expert opinion and how it can be harmful. We look at the problems associated with the evidence-based medicine approach and how we can form solutions to these. We look at the use of this approach within consultations using clinical prediction rules. We look at different types of clinical questions in therapy, diagnosis, prognosis, etc., and screening. We also look at different sources of information, be they primary sources or secondary sources. We look at study design. But the main thrust of this is introducing you to PICo to help you to structure a clinical question. The learning outcomes are that once you have completed this class, you should be able to explain the underlying principles of an evidence-based approach to healthcare delivery. You should be able to structure a clinical question in the PICo format, and you should be able to outline the evidence basis for common drug treatments. These are assessed in various parts of your rotation at an end of year. So in the end of year rotation, you have a portfolio of assignments, one of which contains an evidence-based medicine assignment. So this is assessed here. It is also assessed in MCQs, in the key features questions, and also in the OSCE, where there will be one station on the clinical encounter sheet where you will be asked about a particular patient you have seen during your posting. Evidence-based medicine is an approach to healthcare delivery which is both conscientious and judicious and uses the best available evidence in the care of individual patients. The term used initially was clinical epidemiology, and effectively it is the transposition of population-based health approach to individual patients. But this has to be integrated with clinical skills and clinical experience and acumen, as well as the patient's requirements and needs, etc. These are 2 major players, both now deceased. Archie Cochrane died some years ago, and Dave Sackett died just over 1 year ago. Archie Cochrane was the force behind and the influence on a lot of doctors to develop this approach, and his name is now remembered as the Cochrane Collaboration, the Cochrane Library, etc. David Sackett was the first professor of evidence-based medicine at McMaster University in Canada, and subsequently developed the Center for Evidence-Based Medicine at Oxford University in the UK. These are the 4 A's of evidence-based medicine: ask, access, appraise, and apply. So you should ask a structured, specific clinical question. By that we mean, don't just simply ask, is trimethoprim better than nitrofurantoin in treating urinary tract infections? You have to define what you mean by better. Be specific. So does it lead to, for example, earlier resolution? Does it lead to reduced need for reconsultation? Does it lead to reduced need for analgesia in women with urinary tract infection? as examples. You then access relevant information from various sources, both primary and secondary, in order to answer that question. You then need to appraise that relevant information for its validity and relevance to your patient. And then, if you're happy with all of these, then you need to apply it to your patient. We should teach you these skills because over time, your clinical performance will deteriorate. You need to be engaged in lifelong learning as knowledge is changing rapidly. There are at least 2,000 new Medline papers added to the bulk of the medical literature daily. So you need to be able to find, appraise, and apply evidence for the care of your patients. And this is the ultimate aim, is to improve patient safety, improve patient outcomes, improve quality of healthcare delivery through marrying up these three stems of this evidence-based approach: individual expertise from the doctor, the patient's values and expectations, and the best available evidence. It's worth reflecting on some statements recently published about 21st century doctors. It is now widely agreed that a doctor who currently cannot critically read a research paper, that is, critically appraise a research paper, is as unprepared as one who cannot take a blood pressure or examine the cardiovascular system. Information access and information appraisal is more critical to successful, good quality medical care as these skills are. And graduation from a medical school should not be conditional on students demonstrating clearly that they can do this by means of a year-end portfolio of critically appraised clinical topics. And this is exactly what we do, and you will be doing in family medicine. Let's look at a case. This is James O'Sullivan. He's a 45-year-old smoker. He comes to you with a cough for a week and a bit of breathlessness. No significant history, no medication, no allergies. Father died of lung cancer. On examination, nothing remarkable. Probable chest infection, which you offer treatment for. In addition, you suggest maybe smoking cessation would be a good option. But at this moment, he's very busy at work. He's got a tight schedule. He really wants to get rid of this infection, and smoking cessation is not a priority right now, but he promises to come back and see you about it. How do doctors make decisions about diagnosis, about treatment? Have a think about that. Let's look at some of the possibilities. Well, they could ask a colleague. They can check in a textbook, although it may be out of date. They may look at a journal. They may decide on treatment based on whether the patient is a public patient or privately insured. They may decide based on litigation fear, particularly if they've been previously sued. They may over-refer or over-diagnose and over-treat patients for a considerable few months afterwards. They may look at some online resources such as GP Notebook or Quick Medicine, and they may look at specific EBM resources and journals, and their own prior knowledge also comes into it. But you'll see there's a large gap here where there's a hole waiting for something to fill it, and here it is. Pharma sales reps who come into doctors' clinics and give them the latest information about their latest drugs. How they present that information does matter. Let me give you an example. And the question here is, does overemphasis on relative risk reduction exaggerate likely benefits? It also may minimize likely harms. So let's look at that in sequence. Let's look at a study that was done on patients who are in the coronary care unit, have just had an acute myocardial infarction, and their background medication would be a combination of antiplatelet drug like aspirin, clopidogrel, beta blocker, ACE inhibitor, and statin. Now, this drug that is under scrutiny in this randomized controlled trial is a drug that would aim to improve survival in addition to the effects of these four drug groups. The results are now in and show that there was an absolute risk reduction of 2%. So of 100 patients, 4 died who were treated by placebo, and 2 died who were treated by the therapy under scrutiny. Therefore, the absolute risk reduction is 4 minus 2, and that's 2%. The question now is, would you be likely to prescribe this drug on the basis of these results? The answer, probably not. It's very low figures, 2% risk reduction. However, if you present this data in a different way, same data, it's different presentation, you may change your decision about prescribing. Okay, if we go a bit far and call this drug cure-it-all, but it says here in bold capitals, it halves the risk of death after heart attack. Now, would you be more likely to prescribe this? Absolutely. This is the same data, just presented differently as a ratio. This is the relative risk reduction. This is the risk reduction. It's the death rate in the treatment group divided by the death rate in the control group. 0.5 or 50%. 50% is very impressive. 2% is not impressive. There are other aspects of the pharma industry in its relationship with the medical profession that are of concern. So how can 25% equal 2%? So if you get a 25% relative risk reduction, how can that be the same as 2% absolute risk reduction? You need to know the background risk, the baseline risk, in this case cost, but we'll look at risk. And if the background risk is high, so if you've got a 40% risk of having a heart attack and you give that patient a statin, which has a relative risk reduction of 25%, then you'll get the reduction as 25% of 40%, which is 10%. If, however, your baseline risk is very low, you have no ischemic heart disease prior to this, you're slim, you're not overweight or obese, you don't smoke, you exercise regularly, you're not diabetic, and you have no family history of coronary artery disease, then your overall risk is very low. In fact, it would be much lower than this. It would be something like about 1 to 2%. You would still get a 25% relative risk reduction if you were given a statin, but in your case, it would be 25% of your baseline low figure. Hence, the absolute saving would be much lower. If you see figures in studies showing a benefit of 10% or more, certainly if it's 20, 30, 40%, then it's always relative risk reduction, not absolute risk reduction. What about expert opinion? How does that harm? Well, in the 1970s in the US, myocardial infarction was a big cause of death, and most of those deaths were sudden deaths. And most sudden deaths are arrhythmic deaths due to either sustained ventricular tachycardia, then becoming ventricular fibrillation, or ventricular fibrillation itself. Bernard Lown was an influential cardiologist and guru who suggested sensibly that flecainide, a drug that suppressed arrhythmia such as ventricular tachycardia, should be given to all acute MI patients. This was done in the US, not in Europe, not in Australia, but they didn't look at outcomes until much, much later. It was well over a year, it was almost 2 years. If they had looked earlier, they could have seen that flecainide was killing patients. The death rate in the flecainide group was much greater than in the placebo group. And in fact, more adults had died from flecainide than had been killed in the Vietnam War. Here's another example where using thrombolysis. This shows a forest plot, which is a visual representation of a systematic review of several randomized controlled trials. These are all individual trials from 1969 up to 1979. And on this plot here you have, this is the line of no effect. Each of these is each of the constituent randomized trials. The lines representing from here to here the confidence interval, so this is a narrow confidence interval, this is a wider confidence interval, and the dark blocks represent the effect size of the trial. If these lines cross the midline, the line of no effect, then they're not significant. And this black diamond shape at the end is called the pooled estimate, and this is the estimate of pooling or summing together all of these different trials. And what it showed was that thrombolysis was of definite benefit in treating patients with acute myocardial infarction. So there was no need to do any further trials after this point. But several trials went ahead up until the 1990s, and this is ethically and professionally unjustifiable. Dr. Benjamin Spock was a pediatrician, an American pediatrician who was highly influential in how parents brought up their children, particularly mothers. But on the topic of baby sleeping position, he was quite wrong. And this is another forest plot summarizing several studies from 1965 up to 2003. And this shows all of these studies disagreed with Spock, and they were all significant apart from the first two. But the summary, pooled point summary, shows that Dr. Spock's suggestion of that babies should lie on their tummy was incorrect and may be linked to a likelihood of sudden infant death syndrome. We now know that the opposite is the case, and babies should lie on their back. So if the approach using this evidence-based practice is so clear, how come doctors aren't using this? So what barriers are there to them using this approach? The main one that's cited is time. They have limited time to do this. It takes a lot more time. The consultation time would be lengthy. It gets much more stressful, etc. They may also have an attitude that disagrees with this approach. They may also have not been trained. They may not have the knowledge or skills. May not have had been any tutorials as undergraduates or as postgraduates. For non-consultant hospital doctors in Ireland, and this may also apply to Malaysia, junior doctors have very little possibilities of changing practice within a ward structure, for example, as they are overridden by their seniors. So there are three main problems in the modern world in relation to evidence-based medicine. One is the explosion of literature. There's so much stuff being produced. One is unmet information need. There are lots of clinical questions that arise, but they don't get answered because of pressure of time. And there's huge implementation delay between knowledge becoming available and then being transferred into practice. So knowledge translation into practice takes a long time, on average 17 years. But you've seen in the case of Benjamin Spock that baby sleeping position took almost 50 years before that changed. A solution here is to use pre-appraised summaries. These are reviews with critical appraisal, and they're presented for you in easy, assimilatable, bite-sized summaries. And you get these from the Cochrane Library, from UpToDate, Dynamed, Evidence Update, PubMed, and also other sources like BMJ Clinical Evidence. So how about using evidence in consultation? Does it take a lot longer or not? Let's show two examples of clinical prediction rules which actually can be performed very quickly, and this consultation would take no more than 2 or 3 minutes. This is the Ottawa ankle rule. It's designed to assess patients who've had ankle injuries to decide whether they need radiography because the suspicion of fracture is high or not. If the patient can bear weight and is not tender in the areas shown here, and also including the base of the fifth metatarsal, then the likelihood of fracture is very low, and that patient does not require radiography. This is a clinical prediction rule. It's also a decision support system in that it helps you not alone to diagnose, but also decide on management. Here's another example. This is called the modified Centaur score for streptococcal pharyngitis or suspected streptococcal pharyngitis. Effectively, patients who come with a sore throat would be assessed using a Centaur score. If they are under 14, they get 1 mark. If they have an exudate on their tonsils, they get a mark. If they have tender lymph nodes, they get a mark. If they have a fever, they get a mark. If there's absence of cough, they also get a mark. So it divides patients into those who have likely bacterial cause for their sore throat, and those who have a likely viral cause. So low score in the center score would be viral, high score would be bacterial. And if they are somewhere in the middle, then the management of these would be to provide them with an antibiotic and an information pack from patient.co.uk, but their prescription should not be dispensed until a week later, providing the patient is still unwell. If the patient improves, as the majority do, 90% do, then they don't need to get the prescription dispensed. We mentioned about clinical questions earlier, and these are questions that can be posed to you directly by your patient, or they may be questions that may arise in your own mind during a consultation, and they come in all shapes and sizes. There are questions about therapy, such as this one. There are questions about diagnosis, such as this one. There are questions about prognosis or outcomes, such as this one. And finally, questions about screening, such as this. So let's look into the structuring of a clinical question using the PICo format. Patient, intervention, comparison, outcome. Patient could also stand for population. Intervention is sometimes also seen as exposure, comparison, and outcome. So let's have a look. Let's look at a case to illustrate this. This is a very common consultation that you will see often in your postings. A mother brings her 7-year-old son to see you with right-sided earache. He's had this for 3 days. There's been no discharge. He's distressed by the pain. He's otherwise well, with no significant past history, in particular no asthma. The mum has tried liquid paracetamol with little benefit. He's still in pain. And she tells you, right, doctor, he's suffered enough. I want to get it sorted. I don't want him to miss school or to have to come back here to see you again. So will you please give him an antibiotic now? So let's structure a clinical question around this mum's query using PICo. Subsequently, if you want to look back on the PowerPoint presentation, you can actually look here, and this gives you some structure in how to formulate clinical questions. So, who's the patient here? We know this boy is 7. But there's another crucial bit about him that we know, that he's got acute earache. So, school-age child with acute earache. You don't need to differentiate boy, girl here at this point. The intervention would be an antibiotic. You don't need to specify type of antibiotic, just oral antibiotic. And the comparison would be either, as it states here, symptomatic relief only. You could also put in here nothing, or placebo. And the outcomes, well, the mother has already suggested the outcomes to you, and they would be reconsultation rate over the next 2 weeks. Is he more likely to come back and see you because he didn't get an antibiotic? Resolution of symptoms, or particularly time to resolution of symptoms, and also time off school. Let's look at another case. This is James O'Sullivan, the man in whom you diagnosed pneumonia sometime earlier. He's now come back to see you. Originally, you had suggested nicotine replacement therapy, but in the meantime, his friend Donald had no success with that whatsoever until his doctor gave him this other compound called bupropion. So James O'Sullivan has not come back to see you to say that, yes, he wants to engage with smoking cessation, but could he have this instead of the NRT? You're not sure if this is as good as, or better than, or inferior to nicotine replacement therapy, so you want to structure a PICo question to find out. So, who are the patients here? He's a 45-year-old man and he's a smoker, so middle-aged smokers. The intervention, bupropion. The comparison, nicotine replacement therapy, or NRT. You could switch these around. NRT could be the intervention and bupropion the comparison. It doesn't matter. The outcome. Specifically, you want to look at long-term abstinence rates. These are usually about 6 months in duration. So the question then, when it's clarified and structured, becomes, in middle-aged smokers, is bupropion more effective than NRT in improving long-term abstinence rates? And in fact, on the PowerPoint later on. You can look at this, and this is a systematic review looking at effectiveness of a variety of smoking-related smoking cessation therapies. Question of diagnosis is slightly different. It's not PICo, it's referred often as PIRD. And effectively what you're doing is comparing one way of diagnosing a condition with another, the other being a gold standard or reference standard. You then calculate the diagnostic accuracy of the index test versus the reference standard. So let's look at an example. This is about young women with uncomplicated recurrent urinary tract infections such as cystitis. So this is your population. These are women at least 18 years of age with no pregnancy, diabetes, hypertension, etc., with a history in the past of recurrent UTIs. And what you're comparing is the index test. This is slightly unusual in that it's not actually a test. It's not actually a test as such. It's self-diagnosis. So these are women who, on the basis of having had these symptoms in the past, they recognize them when they recur in the future. So when they have the symptoms now, they're fairly sure that these are due to cystitis. So you're comparing that knowledge, that self-labeling, with a blinded laboratory culture. So it's very important that this is blinded, so that the doctors in the laboratory doing these culture tests do not know that this sample comes from a woman who has self-diagnosed or not. And what they find is that the diagnostic accuracy of self-diagnosis against culture-positive urine is 84%, which is quite high. Prognosis is slightly different also. There's no intervention as in a therapy question, so there's no PICo structure, but there is a PEO. So you have a population, you have an exposure, and then you have an outcome. There are two main types of cohort study as they're described. They can be inception cohort or prospective cohort, or they can be retrospective cohort. In a prospective or inception cohort study, you have a population and then you follow them over time. The exposure could just be time. And you want to see the outcomes. So for example, when the population of Framingham, a town in Massachusetts, was followed up looking at weight, blood pressure, and various other things such as cholesterol levels, ECG, etc., they were able to predict which of these patients would develop coronary heart disease, heart failure, etc. And subsequently, this knowledge was translated into the derivation of various cardiovascular risk charts, like the score chart, etc. A retrospective cohort means that you already have the outcomes now, and then you look back through case records to see what exposure there was in the previous 10, 20, 30 years. Here's an example of a prognosis question being answered by a cohort study. This was a famous paper on mortality in relation to smoking. It was a 40 years observation on male British doctors, which you can look at in your own time. Screening is a system to identify disease which is asymptomatic, when it should then be more easily treatable and then lead to a better outcome. These are the various criteria for a valid screening test. There should be a burden of suffering. In other words, the condition should be common, it should be detectable early, and the test should have accuracy and validity. It should have a very low false positive rate, and also should have a low false negative rate too. It should be acceptable. So for example, a simple test like a blood test or a breath test would be acceptable, but a liver biopsy or a kidney biopsy would not be acceptable. There should be evidence that there's improved outcome if this condition is picked up early. One of the difficulties with screening, for example, is the concept of overdiagnosis. So this is quite common in breast cancer screening and in prostate cancer screening. And actually it's emerged as the most important harm of breast screening. If a woman is labeled as having breast cancer, but in error, The psychological damage is immense, and it stays with her probably forever, certainly for the foreseeable future. The error could be that the cancer that's detected is a slow-growing one, and therefore will not harm or kill the woman. It could also be that it's not a cancer at all, it's a form of fibroadenoma, fibroadenosis that's been misinterpreted by mammography or clinical examination as being a cancer. And the problem then is that there's also a media thing, there's a media promotion of the fear of disease, which perpetuates the myth that early aggressive treatment is always best. And in an attempt to avoid litigation, doctors have begun to leave no test undone, no abnormality overlooked, and profits being made from the screenings, medical procedures, and drugs. But this can be immensely harmful. This is also true of prostate cancer screening. This is a cohort study on the effect of screening mammography and breast cancer mortality in Norway. The Nordic Cochrane Group have provided very clear advice about breast cancer screening, and they say it comes down to a discussion with the woman on the level of overdiagnosis. And if the overdiagnosis level is acceptable to the woman, then you go ahead and screen. That's their view of it. We will look at evidence sources and searching for them separately in a separate class. The two main sources, primary sources and secondary sources. I've drawn the analogy here with food, which is always a good analogy in Malaysia. So let's say you've had a long day at college, and then you have to go and eat. You can either go home and cook, you have to source ingredients, need to plan and cook. It's a slow process. The outcome could be very good, but it can be slow and tedious. This is the analogy with PubMed, finding stuff from scratch. You can, on the other hand, just go to your local nasi kandar and get a really good lamb biryani, which is of high quality, already prepared for you. It's quick and reliable. The analogy here is one of those pre-appraised sources such as the Cochrane Library or Dynamite or UpToDate. You must know how to use PubMed. You must have these skills, because there'll be times when this will not provide the answer for you, and you need to search through other sources. If you have a question about therapy, what kind of study design would answer that? Well, if it's therapy, it would be either a randomized controlled trial or a collection of randomized controlled trials, as in a systematic review, and this would provide the better answer. There would be more reliable conclusions could be drawn from this than from a single trial. What about prognosis? Remember that case we had of the middle-aged smoker? Well, let's say he develops small cell lung cancer, and then you want to know the 5-year mortality. This will be done through a cohort study. And here's an example here of a cohort study on just that. If your time is tight, you've no time for PICo, on Moodle, this is available to print off. You can jot down quick notes and then look it up later. Don't forget the 4 A's of evidence-based medicine. We've included the 5th A here, which is audit. So when you've done all this, then maybe a year later you would go back and re-audit your outcomes. Also, you should remain curious and skeptical. Just because something is published in the BMJ, the Lancet, JAMA, New England Journal, or any other journal that's highly regarded, don't assume that it's good quality. And don't assume that what you're told is correct, even by me. Always be ready to ask, how do you know that, Prof? How do you know that? Don't forget your friend PICo. There's some references for you. This is an excellent source here. This is based in Oxford. This is Students4BestEvidence. They also have a Twitter feed. They have a website. They explain the whole evidence-based approach really well. There's also the Excellent Centre for Evidence-Based Medicine at Oxford. JAMA Evidence also produces these wonderful podcasts, and I would particularly urge you to listen to the first one, which is called What is the Question by Dr. Gordon Guyat from McMaster University. And Testing Treatments is a very, very useful resource for explaining evidence-based medicine. Thank you for watching this video.